A very good morning and a warm welcome to the day 2 of CapCon 2024. We have August personalities present with us today, and we are very much honored to continue the lamp of learning that was lit yesterday by another academic extravaganza today. For the first session, we welcome Dr. Rajat Mukherjee and Dr. Navonita Banerjee to chair the session. Sir, madam, please come on stage. Dr. Mukherjee? Okay. Yes. Since we are already slightly behind schedule, I would request all of you to come and take your seats as soon as possible so that we can continue with the several extremely interesting academic programs that we have lined up, followed by which we will be having the award paper sessions, then lunch, and finally the handing out of the certificates. Thank you, sir. For the first talk today, we welcome Dr. Vikas, who will speak on novel biomarkers in the management of autoimmune disease diagnosis. Dr. Vats, please.
Good morning, all. I would like to thank organizers to give us the opportunity to talk in this AppCon 2024. So today I will talk about the novel biomarker in the management of autoimmune disease diagnosis. So before to go to the talk, I just want to give the brief introduction about Verfin. Verfin, we have worldwide operations. We have headquarters in Barcelona, Spain, and we have 5 different verticals in our organization. Hemostasis with the brand name Instrumentation Laboratory. Then we have acute care diagnosis, which is we have the Rotom machine, and then we have autoimmunity with Innova Diagnostics, and then we have OEM manufacturing as well as the medical device division in our company. And recently we have acquired one more company, Immucore, that is for transplant and transfusion. So in globally we have more than 40 countries we have direct representation, and in India is one of them. So when we talk about the autoimmunity, early detection is very, very important. Because if we will detect the patient early stage, then we can prevent disease and we can go for the disease, we can prevent the damage and disease progression. So if we'll see the data for the diagnosis of autoimmune diagnosis in 2014-15 published that patient take 4 to 5 years to get the correct diagnosis in case of SLE. And same way, patients visit more than 5 clinicians to get the clinical diagnosis. So what about the mortality rate? So this is a complex disease. It's not very straightforward. So we have to look a lot of options for the disease diagnosis. So ANA screening is the one of the entry criteria or screening the patient in case of SARD, systemic autoimmune rheumatic disease. So in 2008, ACR has developed initiated a task force, and then they visited a lot of KOL and scientists in the worldwide, and 2009 they came with the statement that ANA HAP2 is preferred method for screening. And recently in 2019, ACR ruler criteria, they have changed the guidelines. They have said that 1:80 or above is the initial entry criteria for ANA IFA screening. Before that, people were using 1:40, where 1:40 will get the more than 30% healthy population come as a positive in that. So that is why they have changed the 80, and now currently 160 is the referral. If any patient comes positive in AFI screening at 160 dilution, that means there is a clear-cut warrant that patient have autoimmune rheumatic diseases. Then in 1960, mainly we get the prescription from the rhemat only, but nowadays we are getting for the other care centers also, like primary care, hematology, nephrology. So a lot of requirement we are getting from the different department. And ANA IFA is still the gold standard as a screening tool. So this is the algorithm. If the patient comes positive on ANA HEP2, then we have to go for solid phase assays for the confirmation. So for that solid phase assay, we'll consider as chemiluminescence or ELISA is the best method for, because they give the numerical value, quantitative analysis. Whereas if we'll consider blood, that is also as a screening tools, where we are not getting the correct numerical values. So autoimmune, because we can easily know the disease progression and flare, so that is why always once we screen the patient, we have to go for quantitative analysis. So future direction, we have done the study of more than 5,000 patients, and we have checked the three methodology. One is called ANA IFA, then fluorescence immunoassay and CLIA. So what we found that there is no 100% correlation in on these two IFA and solid phase assay. In ANA, we missed out of that, we missed 44 patients. Same way in connective tissue disease screening using CLIA, we missed the 38 patients. So what is the conclusion? So then we reviewed the published public articles, and the scientists worldwide, there is no common consensus which one is the best preferred method for ANA screening. Some say that for SLE, CTD is better. Some they say Sjogren's syndrome, CTD is better. So this is not common consensus. So what to do? So then we can replace the IFA screening? No, not yet. So this is the best method to screen the patient. We have to do IFA and CTD screen both. If both come positive, then we can go for ANA sub-serology, because it's just a screening test. So this is the best method. Then there is one more marker called DFS73, because this is attributed non-rheumatic diseases patient testing IFA positive. So we found that 50% of the false positivity attributed by DFS70 onto the present high titer and isolation without the CTD association antibody, except as exclusion marker for connective tissue disorder. So this is also we need to incorporate in the screening part. So this is the latest publication from Canada. They have incorporated DFS70 in their screening part. What they are suggesting, if ANA IFA come positive, then they have to go for ENA profiling. In EFA profiling, if certain number of patient comes negative, then they have to directly go for DFS70. Because what happens when in screening patient comes negative in ENA, then they go for follow-up. If we can exclude these patients, then we can save more than 30% cost saving in the screening, because then patient will not suffer again for AFA screening. So we can exclude using DFS70, and we can commercially also we can give the benefit to the patient. Then there is one more marker called RO58 and 62. So this is basically two molecules for SSA. So then if RO52 comes positive, that is the case of inflammatory myositis or polymyositis. And if only 60 will come positive, then this is the case for SLE. If both will come positive, then it's the Sjogren's syndrome. So we have to screen both the marker independently, not in the together, because there is a masking effect. So then another marker is POL3, which is identifying 11 to 23% of systematic sclerosis patient, and it has been included in 2013 ACR-ULAR classification guideline as well. So that is also we need to go for individual screening for this marker once the ANA IFA comes positive, and we'll get the ENA also positive in that case. Then another case is called immune-mediated myopathies. So there is a myocyte-specific antibody, and this is very complex disease, because immune-mediated myopathy patient might present several extramuscular manifestations which can make diagnosis challenge for the clinician. So that is why we have launched the marker HMGCR. That is for the immune-mediated necrotizing myopathy patient. We can easily rule out with this and then change the disease treatment as well based on HMGCR positivity. And HMGCR antibodies present in 5% of the immune-mediated myopathy patients, which have a higher association in immune-mediated necrotizing myopathy. So this has been already published in Autoimmunity Review, and we have a lot of publication on that. Even from India, we have one publication from SGPGI. So, and Dr. Lalpath is doing regularly this test. Earlier, this was test going to the US, but we have launched in India itself. Then HMGCR also helped to the clinician decisions. 83% of the clinician reported that identification of myositis antibody influenced their diagnostic confidence. So they have suggest that we have to do HMGCR also for immunodeficient necrotizing myopathy patient. So then novel biomarkers in antiphospholipid syndrome. If we see in the lab diagnosis, it look like very simple. We have to do triple positivity, but in real world, in clinical setting, it is very difficult. So this is the latest guideline in 2023 ULAR APS qualification. They have not changed much, just they give it the domain 8, whereas the domain 7 and 8 is the laboratory diagnosis, where they have suggested to do antiphospholipid test, folate phase assay, cardiolipin, and beta-2-GP should be do on ELISA. And also they have suggested to do this lupus anticoagulant. So these are the two tests they have recommended. And they have also given the scoring system. But unmet need of ABS, because using clinical criteria is just for the research application. It is not for the diagnostic application. That is why we need the novel biomarker to diagnosis. For that, these are the promising marker like beta-2-GPA, antibody domain 1, and phospholipid syndrome, antiphospholipid phosphothreomine complex. This is PSPT. These are the very promising non-criteria antibodies. So PSPT is the one of the marker which is very, very promising. It was first published in 2010. Then we have publication in 2013, and it was clinical relevant. And since then, now we have hundreds of publication on PSPT. And India, we have 2-3 labs, they are doing PSPT regularly. And this is basically for the antiphospholipid risk assessment. And when using PSPT, introducing PSPT antibody in the diagnostic process for APS might present in the further valuable diagnostic tool is especially risk assessment of asymptomatic antiphospholipid carrier, because beta-2-GP1 is the basically 4-5 domain structure. So that is why it sometimes come positive in carrier as well, and high clinical suspicion in APS, but negative for triple positivity. When antiphospholipid turn negative during follow-up, that also we can go for PSPT, and if the patient on anticoagulant therapy, then also we can try in this marker. This is the domain 1, because as I said that domain beta-2-GP1 has a 5-domain structure, whereas the domain 1 is very specific. So this is the publication already well published. And domain 4-5 antibodies detected among the asymptomatic antiphospholipid carrier, where domain 1 was present in women with APS history of obstetric mobility and APS patient with history of thrombotic event. So this is also unique marker. This is the algorithm we can go for. If the triple positivity will come, then we likely APS is high. If only 2 marker will come, then APS is moderate. If it is negative, then we can go for the additional testing in these cases, but like PSPT and then. So this is easily available in our website as well. So this is the machine, which is called chemiluminescence. Why it is better? Because ELISA has 0 to 500 analytic dynamic range, whereas CLIA has 0 to 4,500. And we have the machine where the reaction happen in suspension, not in the...
Dr. Vikas, your time is up.
Yeah, this is last slide only. Thank you, sir.
Thank you, Dr. Vikas, for a wonderful presentation. We'll have the question and answer session at the end of this session. The next speaker is Dr. Subhra, or our own Dr. Subhra. She needs no introduction. One of the most erudite pathologists that we have in town and in the country.
No.
Very elegant and very learned.
Can we request
Dr. Subhra? Sorry?
Can we request Dr. Vats to come once on stage to get the...
Oh, yes, Dr. Vikas, if you could come once. Sorry, yes.
Roger sir, can... Thank you, Dr. Vats, and thank you, Dr. Mukherjee.
Thank you for that kind introduction, Dr. Rajat Mukherjee. Good morning, everyone. So today, I'm going to discuss the cutaneous manifestations of autoimmune connective tissue disorders. I'm going to show you some clinical scenarios and cases of the commonly encountered skin lesions of autoimmune connective tissue disorders. A brief introduction first. autoimmune connective tissue disorders are chronic inflammatory disorders. I need a marker, pointer. And they are associated with the complex interplay of genetic and environmental factors, resulting in a variety of systemic and/or cutaneous manifestations. Skin lesions may precede, coexist, or follow systemic disease in conditions like SLE, scleroderma, which may be systemic or localized, dermatomyositis, rheumatoid arthritis, and mixed connective tissue diseases. SLE, or systemic lupus erythematosus, is one of the common autoimmune diseases with a reported prevalence of 14 to 60 per 1 lakh population in India. The triggering factors are genes, environment, immune, and inflammatory influences, as we have been hearing since yesterday. The skin manifestations of SLE include lupus-specific lesions, which are the malar rash, generalized maculopapular rash, discoid rash, subacute cutaneous LE, and lupus profundus. Lupus non-specific lesions are also present. They can also manifest on the skin in the form of non-scarring alopecia, oral mucosal ulcers, vasculitic lesions, bullous lesions, Raynaud's phenomena, and erythema multiforme. This is a chart showing the prevalence of cutaneous manifestations in SLE over the entire course of disease. And look at the percentage of cutaneous manifestations is quite high. It is 80%. The highest percentage is seen in the form of photosensitivity. Malar rash occurs in 50% of cases, oral ulcers in 40% of cases, alopecia in 40%, discoid rash 20%, vasculitis rash 20%, and others like urticaria, subacute cutaneous LE can occur in 15% of the cases. There are 3 categories of LE-specific skin diseases: acute, subacute, and chronic. Coming to the clinical scenarios, a 40-year-old man presented with indurated plaques coalesced to involve a large area of the forearm with complete loss of hairs. There was no pain or itching or burning on the sensation. The duration was of 2 years, and you can see that the lesion has a hyperpigmented border and a hypopigmented center. There are many lesions at the periphery also, and some have coalesced to form this large plaque. And this is the typical histopathology that we see in this condition. Epidermis is atrophied. There is hyperkeratosis, mild hyperkeratosis. Follicular plugs are seen. The rete-ridges are effaced, which signifies atrophy of the epidermis. And you can see moderately dense inflammatory cell infiltrate in the dermis. This infiltrate is seen both in perivascular as well as periappendageal areas. These are the pilosebaceous units, and these are the blood vessels around which you can see the inflammatory cell infiltrate. This is the high-power view, where you can appreciate that the inflammatory infiltrate is composed mainly of lymphocytes. It is admixed with some amount of histiocytes. And here you can see the slight vacuolar alteration of the basal cell layer, because of which the melanin has fell into the dermis, and the macrophages have come and engulfed the melanin. This is known as melanin incontinence. So that is a very typical case of DLE. We go to the next case. 24-year-old male presented with hypertrophic, hyperkeratotic, scaly plaque just below the earlobe. In this case, the duration was of 3 years. And look at the hyperpigmentation that is present at the periphery of the lesion. You can see some small lesions here. And if you look carefully, there is one inside the ear too. Now, this is a sanctuary site for DLE. In this case, the epidermis is not atrophied. Rather, it is showing some amount of acanthosis. The inflammatory infiltrate is slightly more than what we saw in the last case. The melanin incontinence is also more. The inflammatory cell infiltrate again comprises of chiefly lymphocytes, and if you look carefully, you will find some plasma cells, and occasional eosinophils will also be there. Infiltrate is both perivascular as well as periappendigeal. This is a pilosebaceous unit. So in both these cases, the diagnosis is discoid lupus erythematosus, and this is the commonest form of cutaneous LE that we encounter in our practice as a dermatopathologist. DLE is present in 20 to 30% of cases of SLE. It is most common in 20 to 40 years age group. It can also affect infants and elderly, affects females more than male, and 30% of cases of DLE may have systemic LE. Next, we come to a 42-year-old male who presented with psoriasiform lesions on his chest of 1 year duration. He complained of mild burning in the lesions on exposure to sun. These are the lesions on the chest, plaque lesions, and they also look erythematous. In this case, you can see that the epidermis is showing mild irregular acanthosis. These are the retiridges, which are slightly elongated. Mild hyperkeratosis with follicular plugging is there. The dermis is looking slightly edematous in the upper part. And again, you can see the inflammatory cell infiltrate is quite dense, and it extends from the upper part of the dermis right to the lower dermis level. These are the blood vessels, and you can see the infiltrate involves the blood vessels. Here, these are all high-power views, the blood vessels, and here you can see a small remnant of a sebaceous gland. It also surrounds the sebaceous glands. And this is an Alcian blue stain, which is nicely positive. You can appreciate the increased amount of mucin that is present in the dermis. I prefer to do the combined Alcian blue and PAS stain because sometimes in these lesions, cutaneous lesions of LE, the basement membrane is also thickened, which is nicely highlighted by the PAS. Sorry about that. So combined with the clinical features, this histopathological diagnosis is now subacute LE. Subacute LE can present as annular or psoriasiform lesions. It typically occurs on the sun-exposed areas of the body like neck, chest, back, extensor arms. Serology is often positive, and 80% of the patients have anti-RO positivity. In 30% of the cases, drugs can trigger the manifestation of subacute LE. Common drugs like hydrochlorothiazide, other antihypertensives, can induce or exacerbate subacute cutaneous LE. Next case is a 23-year-old female who presented with necrotic erythematous rash on her face involving the forehead and malar regions and chin. Lesions were also present on her trunk. She gave on and off history of fever accompanied by body ache and arthralgia. Look at the lesions on her face, on the forehead, in the malar region, also the chin, and her trunk is also involved. These are painful lesions. And here you can see the epidermal necrolysis that has occurred. There is a lot of hyperkeratosis, some parakeratosis is also there, follicular plugging, Inflammatory infiltrate is slightly less than what we saw in the last case. This is variable. The inflammatory infiltrate is variable. You always have to do a clinical pathological correlation to come to the correct diagnosis. You can see the vacuolar degeneration. Lot of macrophages have come and have engulfed the melanin, forming melanophages in the dermis. And you can see the perivascular infiltrate, periappendigeal infiltrate, and the increased mucin in the dermis elicited by the Alcian blue PAS stain. This is the direct immunofluorescence, C3, IgG, IgA, and IgM, and all of them are showing a linear pattern at the basement membrane zone. So this is a full house, positive DIF. And the diagnosis is acute cutaneous LE. Acute cutaneous LE presents as maculopapular lesions, often necrotic. It is a manifestation of systemic LE. Patients usually is already having systemic LE when he or she manifests a rash. And the skin lesions can act as a barometer for disease control. Next, we come to the 7-year-old male child who presented with extensive indurated plaques on his body of 2 years duration. There was occasional history of fever and arthralgia. Look at the severe disfigurement that the patient is showing because of these indurated plaque lesions. And it has involved all the fat-bearing areas of the body. So here you can see the hyperkeratosis in the stratum corneum along with follicular plaques. The pattern is basically the same. Again, periappendigeal infiltrate. These are the eccrine glands in the lower dermis. The infiltrate is extending into the lower dermis. And it is not only extending to the lower dermis, it has come and infiltrated the subcutaneous fat in a lobular fashion. And you can see the nature of the infiltrate. It is mainly lymphocytes admixed with few plasma cells. And that presence of plasma cells actually gives you a good clue. Perieccrine infiltrate and presence of plasma cells gives a good clue to the disease that we are dealing with. Here, the fat is showing some amount of hyalinizing necrosis. Same over here. And the diagnosis is lupus profundus or lupus paniculitis. It is a rare variant of cutaneous LE. Tender, often painful erythematous indurated plaques or nodules are present on fatty areas of the body. Profound lipoatrophy often occurs, leading to severe disfigurement. And sometimes, I showed you a case where the lesions were extensive, but sometimes patient may have a single lesion. In that case, diagnosis is often missed and delayed. 6-year-old girl presented with fever for 8 months, associated with recent onset severe weakness of limbs. There were skin lesions on face and hands, which developed just 2 months back. Look at the erythematous rash present bilaterally on her cheeks. And look at the papular lesions, erythematous papular lesions presenting on the dorsal aspect of her fingers and hands. Almost similar picture like we saw in the last few cases. Atrophy of epidermis. Vacuolar degeneration can be appreciated over here. The dermis looks pretty edematous. You can see melanophages over here. Look at the distance separating the collagenous bundles. The intercollagenous spaces has increased. That is because of edema. And this is a mucin stain, which is again positive in this case. In this case, the clinical pathological correlation With the help of clinico-pathological correlation, we have made a diagnosis of dermatomyositis. It is characterized by dusky red rash on face and eyelids, around nails, knuckles, elbows, knees, chest, and back. Muscle weakness is frequent. Calcium deposits on skin, mechanic's hand are also common. The skin becomes very thick on the palms of hands. But in dermatomyositis, muscle biopsy is the gold standard for diagnosis. These are the lab-specific markers. Myositis-specific antibodies are found in more than 50% of cases. Most common is anti-MI2, anti-Jo1. ANA is positive in 60 to 70% of newly diagnosed cases. A 7-year-old girl presented with hard-bound skin on her upper arm. The plaque was present since 1 year. It was hyperpigmented and hypopigmented at the center. This is the plaque on her upper arm, hyperpigmented at the periphery and hypopigmented at the center. The epidermis is showing slight acanthosis. And look at the dermis. The intercollagenous spaces has reduced. The collagen appears very dense. We come lower down, the intercollagenous space is very much reduced. The collagen appears very homogeneous and dense. And this is another biopsy from the hypopigmented center that I showed you. Here the skin is showing atrophy. There is so much of vacuolar degeneration that a space has appeared between the epidermis and the dermis. There is a follicular plug, and the periacrine area is showing some infiltrate. The infiltrate comprises of lymphocytes and plasma cells. So this was a case of morphia with lichen sclerosus et atrophicus. And the important thing to remember is that these two lesions often go hand in hand. This is another case of extensive morphia along with LSA. Morphia is also known as localized scleroderma and presents as ill-defined brown-colored patches or plaques, often felt as bound down by the clinician. Histologically, it is characterized by massive deposition of collagen, and anti-SCL70 antibody is the autoimmune marker for morphia. So these are my learning points. Early diagnosis is important in autoimmune connective tissue disorders to contain disease burden. Skin biopsies can help in early diagnosis, provided one is aware of various skin manifestations. Clinico-pathological correlation plays a very important role in correct diagnosis. There is power in the punch. This is a very enduring political image of Trump after being hit by the bullet. He's punching the air with his fist. But I want to stress the importance of a punch biopsy. All these diagnoses were arrived at by simple punch biopsy. So don't underestimate the power of a punch. Thank you.
Thank you, Dr. Subhra.
Thank you, Dr. Subhra, for a wonderful presentation. It is really very, very enlightening. We have time for
Questions.
Shall we go for the questions now? So, quick questions, if there are any. We have still some time left.
Dr. Bhatt.
Very nice presentation, and the slides were beautiful. I just want to ask one question, that do we need to do Elsham blue PAS in almost every slide, or something, there are certain clues by which we ask for those stains?
It helps sometimes in case of, like I showed you that hypertrophic lesion of DLE. It was, lupus vulgaris was a clinical differential diagnosis. So it helps. If you get a positive mucin stain, it further confirms your diagnosis. No granuloma was, of course, seen there. But I normally, in case of lupus erythematosus, cutaneous lesions, I normally tend to do Alcian blue pastain.
So when there is a clinical diagnosis of lupus, we should always...
Not necessarily clinical. In my case, I have told you before during the workshop also that I examine my cases, I look at the histology, I look at the clinical picture, I make a clinico-pathological correlation, and when I think that I'm dealing with a case of lupus, I always go for an Alcian blue pastine
Okay,
to
and-
further corroborate my diagnosis.
Yeah. And the other question is like, how often do we look for basement membrane thickening in DLE and all those cases?
See, basement membrane thickening is sometimes quite obvious in the H&E stain also, but it is not always present. You cannot always elicit basement membrane thickening. We follow books, but the diseases do not.
Yeah. So you may not find basement membrane
You
thickening.
may not find it.
Okay. Thank you so much.
Thank you very much. We'll do the honors. The next speaker today is Dr. Sukanto Chakraborty. Seems to be a star-studded morning. He is again another person who doesn't need any introduction. Our dear own Dr. Sukanto and the organizing secretary. I must thank him for doing such a wonderful job. He and Dr. Subhra, they have a zero-error conference, as anyone would call it. Dr. Sukanto, please.
Good morning, all. Thank you all for attending the conference organized by CAB. It is a Sunday morning, and you will have to tolerate a little bit of academics, though it is a time for gossiping and chat and meeting with friends. But still, in the background, there will be some academics. We have organized an entire 3-day conference about autoimmunity and vasculitis, and we have speakers of different systems dealing with vasculitis only. So I will stick to only cutaneous vasculitis, and that also which are primarily of dermatological origin or pathology. So what is cutaneous vasculitis? Primarily, by definition, it is injury to vessel wall. You can see in the dermis, there is injury to the vessel wall and inflammation around the vessel wall. There are types of vasculitis like in nodular vasculitis or erythema induratum. It is a skin-only affair. And there are skin components of systemic vasculitis like polyarteritis nodosa, and there are also a subgroup where there is a skin-dominant expression of a systemic phenomena like Henox-Conlin purpura. So, next, in very short, what is the pathogenesis? It is deposition of circulating immune complexes within the vessel wall. This is primary pathology of cutaneous vasculitis. And the potential antigens which cause this are drugs and chemicals as well as infectious agents. And there are a broad group of ANCA-associated vasculitis also. So, when we classify according to the size of the vessels, there are large vessel vasculitis, but this doesn't come in cutaneous vasculitis group very often. There are giant cell arteritis and Takayasu arteritis, and starting from medium to small, they come under the cutaneous vasculitis group because there are skin manifestations of them. So, medium vessel vasculitis are PAN or Kawasaki, and in small vessel there are various groups starting from immune complex deposition like LCV, there is HSP, and also collagen vascular disease associated diseases, which I will not elaborate because there are various speakers on this. So, straight away, we will go for clinical features of what are cutaneous vasculitis, common clinical features. Itching is there and burning is more characteristic. Vasculitis causes, patients usually tell like a burning sensation, a jala, rather than a pain. And there are palpable purpuras, petechiae, urticaria, sometimes vesicles and ulcers, and sometimes livedo reticularis pattern, which is a net-like pattern of reddish-blue skin discoloration, and sometimes there are nodules also. And we all know systemic features of vasculitis are fever, arthralgia, myalgia, abdominal pain, etc. Next is some clinical pictures of our skin biopsy patients. So these are, you can see the small purpuric spots, mostly in the lower extremities. This, the second picture is a little bit fade. I don't know you can make out or not, but yes, in the screen it is more, more prominent than my screen. It is purpuric spots, mostly in the lower extremities. And some more prominent pictures downloaded from net, small ulcers and scars, and this is also a vasculitis pattern of clinical picture. So, in cutaneous small vessel vasculitis, which are the more predominant, more common, more big group, there is purpura, papules, vesicles, urticaria, nodules, everything can occur, but purpura is the most common. In urticarial, there is, again, purpura and urticaria is most common. In HSP, purpura is more. In pan, Wegener, everything, purpura and nodular pattern, these are more common. So, now, when to perform a skin biopsy in cutaneous vasculitis? The timing is very important. To